Hi, Lawrence LeBrocq, Managing Partner and CEO of Garces, Grabler LeBrocq. Welcome to Victim to Victory, the authority in personal injury. Today, we have a special guest with us, a fantastic orthopedic surgeon, specializes in sports injuries and traumatic injuries, Dr. Sheref Hassan. He's with Landa Spine, but no, he's not a spine surgeon. His partner, Joshua Landa, does the spine surgery over there. Tell us a little bit about how you met Josh and how you ended up getting involved with Josh Landa and coming up here from the Baltimore, Washington area.
So I actually connected with Josh on the practice a little bit into my earlier career. I started out as a full-time attending at Mount Sinai. It was my first job. I had started a family. We had moved to New Jersey. I've never lived in New Jersey. And I was commuting back and forth to Mount Sinai pretty much 5 or 6 days a week. It took its toll on me. So eventually I applied. I put my resume on the American Academy of Orthopedic Surgery, and I connected with Josh at that point. Had similar philosophies, easygoing styles, and really no crossovers with our specialties and what we treated. And he felt there was a need to cover some extremity work in his practice. It was very close to home. So I did a hybrid. I joined private practice with Josh probably 3 years after my first job. I still am a volunteer attending at Mount Sinai. I'm there every other week doing surgeries, so I kept that aspect of it, but now it's a balance. So quite honestly, it was a serendipitous meeting at a point where I felt there needed to be a better work-life balance in terms of my schedule and my career, and it's worked out.
Right. Sometimes people don't understand that there's different types of orthopedics, and different orthopedics have different specialties. Now, what do you handle at the practice?
So, in my current practice, I basically treat any problems, complaints, injuries to extremities. Josh or Dr. Landa covers spine-related stuff and anything involving the arms and legs. And I have more specialties within each area. I certainly can't treat everything in every part of the body, but as a general orthopedic training, a lot of the bread and butter common orthopedic injuries, with a focus on sports. So I was fortunate enough to have a very good sports fellowship that covered the gamut between ankle arthroscopy, elbow arthroscopy, some hip arthroscopy, shoulders and knees till our face turned blue. So I had a very robust experience in all those areas and feel comfortable treating them, and I still do.
Well, you were the team doctor for several different sports teams. Tell us a little bit about that. How did you get involved in that, and what teams were you working with?
So when I was in Baltimore and doing fellowship and working with those guys up there, they were covering the greater part of the sports in Baltimore and needed robust coverage from all of us. So it was honestly through them and through my chairman and my fellowship director, but we had a really, really exciting and good experience being on the sidelines and being on the medical personnel and team doctors for the Ravens, like you said, the Baltimore Blast, which is an indoor soccer team for those who don't really follow the sport, and the Washington Nationals. We had an affiliation with Georgetown University and one of the attendings there who covered them. So we went to locker room before spring camps and really dealt with a lot of throwing athletes as well. And a plethora of research opportunities. I got involved with some elbow research in terms of the UCL ligament of Tommy John. I've written a book chapter with some of the guys over there in Baltimore and HSS regarding the elbow and some of the throwing injuries there. And it was through them that honestly I've gotten a lot of that experience.
Well, obviously, you saw all the throwing injuries in baseball. You can get it with some of the quarterbacks, but generally it's in baseball. What's the most common injury in soccer?
So soccer, the two most common things are ACL injuries, unfortunately, and meniscus injuries. So knee, you get your fair share of ankle and ligament sprains, but certainly the knee injuries are much more common.
And then football, you have a plethora of different injuries. But what did you find to be the most common? Was it knee again, or other? I know you're not dealing with concussions. There's a lot of those.
Correct.
But,
Well, we did. So on the
yeah,
sideline, you sort of have to deal with everything. You're a medical doctor first and foremost.
sure.
So even in, we would have our clinical practice, see our patients from day to day, and we would go to the locker room for these teams and have our own sort of clinical office hours, and we treat things like common colds, rashes, and as physicians
Right.
for these teams. And we certainly had other medical providers working with us in different specialties, but on any given day, I would write antibiotics for some issues, etc. So we did cover that. We had to know about it and do it. But in answering to your question, in football, it's positional. So I think depending on the positions, you see different types of injuries because these guys are doing different things and have different mechanics. Linemen certainly do get their fair share of shoulder and knee injuries just because of their position. The defense, I would say, we saw a lot more shoulder problems for one reason or another, and lower extremity, minor things like hamstrings and things of that nature. But there's definitely a mix in football.
Sure.
Yeah.
Uh, for those watching, the reason we're not going to talk about who the doctor treated or what he treated was that would violate what's called a HIPAA violation. So we're not going to talk about names, just certain situations in sports here. Now, going from sports, how does that experience help you when you're dealing with people injured in various traumas, whether it's a trip and fall, an automobile collision, a fall from heights? How does that tie in?
So, I mean, sports is, the activity in which the mechanism of injury happens. So there are similarities with certain mechanisms of injuries. So certainly when we say I'm a sports doctor, I'm not only treating athletes. People get hurt with very similar injury. People can tear their ulnar collateral ligament or their Tommy John from lifting something the wrong way or from a heavy object falling out or from falling awkwardly. It doesn't necessarily have to be a professional pitcher. So it does, help you in treating these injuries and understanding mechanics because you do see a lot of these things in real time. That is some of the, I guess, the advantage and disadvantage is you're there when it happens, but you also see how it happens and you can understand a lot of the biomechanics involved and certainly understand how someone else who may not be doing a sport can have a similar mechanical injury, and that helps you also figure out what the problem is, help with the diagnosis, and really get to the bottom of it.
All right. And we've made such great strides in procedures over the years, surgical procedures, that you mentioned doing arthroscopies. Now, what is an arthroscopy and why is it performed rather than completely cutting open a person's knee or shoulder?
So the nice thing is medicine is constantly evolving. And I can tell you from when I first was in training till now, many things have evolved and have changed, and I've had to evolve with it, including how I do procedures. Arthroscopy is a term, it's broken up into two parts. Arthro means joint, scopy means using some sort of scope or a camera to simplify it.
Right.
So it is now we've developed ways to indirectly get into people's joints without having to necessarily traumatize everything around them. Traditionally, in the older days, without the technology, in order to get to inside of a joint to repair damage internally, you would have to dissect or remove certain things on the outside, whether it be muscles, ligaments, etc.
And you would have to expose it just to be able to see what the injury was because
Correct.
there was no way to diagnose it.
And there are certain joints, in order to get to them, you would actually have to cut the bone, create an osteotomy or a break in the bone, remove that bone out of the way, access it, and then put it back together as if, you're creating a fracture. So arthroscopy has revolutionized that, and now you can indirectly go through the skin through small or very tiny incisions and use a camera to navigate and access different parts of the joints safely without all that dissection, without all that unnecessary surgical trauma to that area. So you say, all right, what's the advantage if you do it nicely both ways? Don't they both heal? Yes, I'm not saying all the old surgeries were bad or they didn't do well, but it led to longer recovery periods, more complications, risk of infections, bleeding. You're now cutting into more things. So all of these add up, and in the right patient, it might not be an ideal situation. You might not even attempt surgery in an open fashion because of those risks.
Sure.
Where now you can do a lot of those things with minimizing those risks, and more importantly, getting these folks back quicker.
Right. Now, there's different types of shoulder surgeries, just like there's more complicated spine surgeries. We're talking, we saw sometimes discectomy as opposed to a pherenotomy, and then you have your laminectomies, and then you have your fusions. There's so many different procedures. What I'm very curious about is what makes you decide whether or not to just do a simple scope. When I say simple, I mean you're not putting in any anchors or screws, or what can be called a Mumford procedure, or using those anchors. What makes the determination in a shoulder of what procedure to perform?
So it's a few factors. One, there are certain benchmarks or guidelines on how to be aggressive with certain things. The most classic example is a partial tear of the rotator cuff.
Sure.
Sometimes we go in there and we debride it or clean it up. And sometimes we go in there and we put a bunch of anchors and sutures to put it back together. Certainly the severity of the injury and the tear is a big factor. If the rotator cuff tendon is completely detached from the bone and retracted or pulled away a great distance, you can't debride it. You have to reconnect it, and that's going to be a more formal repair. Or a partial tear that is, let's say, less than 25% or a quarter of the tendon. You have a very healthy, strong tendon still attached, and just this little piece that was damaged or injured from a trauma that you can debride. Now, there's caveats. You also have to know who you're treating.
Sure.
Okay. So for certain folks, I have partial tears that may not be so severe that in a regular person, you would debride it, not worry. But in a high level, very active person, someone who's lifting weights, who's doing an overhead sport, overhead activity, a construction worker, someone is really going to put a lot of mileage on that joint and really utilize that tendon to its maximum potential, you would be more aggressive with them. I would make sure that I would do a formal repair, reinforce it, give them that ability to not lead it down the road to a secondary surgery or a failure of the primary surgery because it ripped either way. So that's a second factor. You also have to really take into account who you're treating, their expectations, their demands, and also long term. A younger person, you tend to be more reluctant to let something go and become worse over time, so you may be more aggressive with them. Where in an older person, it's really you want to minimize the pain. They're not high in demand. They're not pushing their shoulder to high limits, so they can really manage just well with a simple debridement, a faster recovery, and less surgical time.
And the reason I'm asking this question is not only for our viewers, but I'm also going to show this to our associates because they always wonder, why do I value a certain procedures more than others? Oh, it's just a scope shoulder. No, it's not just a scope shoulder. Did you look? There's been a reattachment here. The bicep tendon was torn. You have anchors. You have screws. It's a little bit different than just your normal scope. So it's very educational for not only for the people watching this, but for the associates at our firm to know what the difference is between a simple scope and a Mumford procedure. Or I know there's other names for the procedure.
A decompression, yes.
And now let's talk about, we'll just go down the body a little bit. Let's talk about the knee because people, always hear, an ACL tear. It's such a common injury in sports. You hear that all the time. They tore their ACL, but there's also the PCL and there's various other ligaments in that knee that can also tear. And then there's the meniscus. All right, why do you need to repair a meniscus?
So the meniscus we found, and it's been looked at, for decades now, is a very, very important structure for the knee for several reasons. It's a shock absorber, so it really genuinely prevents the degradation or the wearing down of the hard cartilage at the end of your bones. That hard cartilage is crucial to preventing arthritis. When people develop arthritis, it means that hard cartilage has worn out. It's much thinner. It's completely bare. It has potholes all over it. Does not function well for a joint that needs to move on many different axes. It's not just a hinge. It's a very complicated joint. So the meniscus, for one, gives you a cushion or a supporting structure so that cartilage lasts or doesn't wear down at all. Secondarily, it's been shown to give you stability. So the more meniscus you lose, the knee becomes unstable, and it's sort of, more fuel to the fire in terms of now you've lost a cushion and the knee moves abnormally, rubs abnormally, puts abnormal loads and stresses on the cartilage, wears away much faster. Sure. So there's been a big push in modern day sports medicine to really preserve and be aggressive in terms of repairing the meniscus whenever possible to keep those benefits.
Sure. That makes sense. And then when do you do an ACL repair, and what are the different procedures that you would do? Sometimes it's just a little tear, and sometimes it ruptures.
Correct.
So how do you treat the different injuries?
So the way we treat ACLs now has also evolved. In the old days, and when I say old days, probably less than 10 years ago, the mention of an ACL repair was sacrilegious. There was very few instances where you can do that and people say, oh, it's going to work. Science has evolved, anatomy has evolved, evaluations, MRIs, implants. So now you can actually repair certain ACL tears. In fact, and I know he doesn't mind me mentioning this, my partner Josh tore his ACL, and it was a repairable type tear, and I repaired it. I didn't put in a graft, and he's a big-time snowboarder, so he's back to doing all of that. So there are certainly very good circumstances where you can preserve the natural anatomy. Another advantage of that is it also leads to a quicker recovery. Sure. You don't have to wait for a graft to take and go through the biological process of becoming a new ACL, etc. So they really bounce back much quicker from it. Those types, there's criteria. So you can't have a rip in the middle of the ACL or an intrasubstance tear just because of the vascularity, the circulation. They don't heal. So even in the best of hands and the best suture techniques, they don't do well. Ones that partially avulse or pull off the bone, which are common injuries, now there are ways and techniques to repair them because the rest of the ACL is healthy and still has some good blood supply, that you can repair them with sutures and anchors as opposed to a graft. Ones that are ripped in the middle or intrasubstance, ones that are more chronic, meaning you didn't get to them early enough, you still have to do a traditional reconstruction, meaning using a graft either from your own body or a cadaver to create a new ACL. Right. Techniques have gotten much better now. We now do things that are called all-inside ACLs. Again, it's even less dissection. It's all done through the scope. Even today, there are some therapists that are confused and say, are you sure this was ACL surgery? It looks like you had meniscus surgery, but it was. So it's gotten less and less invasive. And then with the world of biologics and other augmentation that we can use, we've been able to really speed up some of the process in terms of recovery for folks.
Now, you mentioned that you do treat ankles as well.
Correct.
Do you treat any of those tri- or bimalleolar fractures?
I have, yes.
Oh, yeah. Those are some brutal injuries when you see those.
Some of them, they look pretty bad when they happen, especially the trimalleolar fractures. Yeah. That's a highly unstable ankle.
Just so you know, that's how many bones are in the ankle?
So there's quite a few, but the tibia, the fibula, and then the talus are the main three. Right. We call it trimalleolar because those are the little bumps that you see. There's one on the inside that's from the tibia. There's one on the outside that's from the fibula, and there's one that sort of hinges on the back of that talus bone, and that's part of the tibia. Right. So if any one of those three break, it's considered an ankle fracture, and obviously the more that break, the more unstable and the more problematic it is.
Right. And then how do you repair a trimalleolar fracture?
That's surgical. There's certainly different, depending on the pattern, there's different ways to deal with it. The most traditional way is plates and screws. Yeah. We now have other fancy things with suture materials and little buttons to help reduce the amount of hardware that you have to use in the ankle, but the traditional plate and screw still goes a long way in that.
Sure. I was just reviewing one yesterday, actually, and I saw the two buttons, and I saw, there was unfortunately, 8 screws going in and plates, and very, very severe injury. That's a tough recovery because it's weight bearing.
Correct.
It's just very, very difficult to recover from those. Now, you were talking about some of the elbow surgeries that you do, and you just did a great job describing how that can occur. Tell us some of the things you'll see from trauma. What's the mechanism of injury that you'll see for, say, shoulder tears?
So two most common things, and again, with tendon and muscle tears, the biomechanical way people tear these things, it's usually something called an eccentric loading of the muscle, meaning the muscle is under tension or it's tight and fully pulled, and then there's an added force while it's under that tension. And it's human nature. That usually happens when we're bracing for something. So some of the most common injuries for the shoulder is a fall on an outstretched arm. Similarly, a motor vehicle, most people, when there's an impact, they brace forward. They want to protect their face. They want to protect their head. So the muscles tighten up in the shoulder girdle. Their body weight goes forward and back, the typical, coup, counter coup, whiplash mechanism. Sure. But all that force travels through these tiny little muscles holding everything together. And for a lot of folks, that is way too much for the body to handle. For most humans, it's way too much for the body to handle.
Well, the reason I ask that question, you always hear from defense lawyers, "Oh, well, you didn't hit your shoulder, did you?" Like trying to say, you can't injure how did you injure your shoulder? You didn't bang your shoulder.
It's usually not a direct trauma to the shoulder. There are injuries that happen with that, like an AC joint injury can happen when someone hits against a door. I've seen it many, many times where it's considered, quote, a shoulder separation, but the AC joint opens up from a direct impact. And unfortunately, patients don't know biomechanics. They don't recall. They say, I don't know, I think the seatbelt got me. We know that the seatbelt is not going to be enough. Could it contribute to how their body moved awkwardly? Certainly can. But usually it's bracing. They tense up. They don't want to fly out of the car or hit something. And it's human nature. And that tightening of the muscle with a load applied to it is usually what causes the serious damage.
And what are the most common injuries you find treating people from trauma, and it's not just automobile collisions, but trip and falls or falls from heights in construction accidents? What's some of the common injuries you see with the knees?
So, it's the nature of my practice. I see a lot of knees and shoulders. So most common knee injury I see is probably meniscus injuries. It's common across the gamut and across age groups. And the most common shoulder injury I would see is a rotator cuff tear. Again, very common, very different mechanisms that lead to it. And then from trauma and unfortunate, injuries, fractures. I mean, I think every orthopedic office sees its shares of fractures too.
So what is, we always hear the term slap tear. I've been doing this 35 years. I know what a slap tear is, but what does it stand for?
It's an acronym. So it stands for superior, meaning the top. Labrum is a ring of cartilage that goes around the socket in the shoulder. So it's really signifying where the tear is. So superior labrum is a L, and then anterior to posterior. So usually a tear in the top part of the cartilage ring going from front to back of the socket.
And a lot of times you will hear defense attorneys make the argument of the shape of the acromion is causing that tear. They try to say it's degenerative in nature, it's worn out over time. How do you debunk that argument?
Well, part of it is acromion doesn't communicate with the inside of the joint. So just anatomically speaking, the acromion shouldn't really mess with the labrum at all. And then it's been debated in orthopedic literature whether people develop a spur because of a tear and because of abnormal mechanics over time, or if the spur started and it contributed to the tear. Look, the only thing that can be said about it, it's a risk factor. We all have different anatomies. You have people that play soccer 30 years and never get a knee injury, and you have people that play within a year and they're just as athletic, but they get wrought with knee injuries, and a lot of it is our anatomy. It's very different from person to person, and the acromion is one of those well-known things that has several shapes. It's identified. There's a classification system for it, and certain shapes just impose risk factors. If you have a very inflexible, tight knee, you never really was good with stretching, and you try to do a sport that involves a lot of pivoting and cutting, you're certainly at higher risk for an injury than someone who's very flexible, very mobile, and can tolerate a lot of wiggle room when it comes to this pivoting. So my argument to that is it's a risk factor. Unless you have real hard evidence that it's been a problem chronically for a while, it's diagnosed, there's no other injuries associated with it, then sure, you would have to say, look, this has been a problem that's been going on. It makes sense that it's contributing more to this. Right. But anatomically, people can live with a hooked acromion, with a spur, and never have a symptom in their life unless something happens to cause it.
Can you give us one surgery or person, we don't want to name, of course, that you performed where you said, man, that was a really tough injury and we got a really good outcome? Can you tell us a little bit about the feel-good stories?
Yeah. I have a few, thank God. There was a young woman, and I remember this because it's fairly recent that she's actually contacted the office. She had a bad run with her injury. She was in an MVA. She's a very young girl.
Yeah, motor vehicle accident.
She worked on a ranch. She was a wrangler and a rancher. So she was very physical her entire life, used her shoulder for everything, competed in competitions on a small level, but never really had any issues. Sure. Very shortly after this accident, started having shoulder problems. Have seen several local good guys who tried their best to help her with conservative measures. They've got a couple MRIs. It didn't clearly show anything. So by the time she saw me, I believe she's had already 2 MRIs, had seen 3 surgeons, and no one really had a good answer for her. And she was distraught and really had given up, had said, I think I'm going to have to live and not be able to do this. And right. She felt like she knew physically something was wrong, but she felt nuts, right? And that's what she said. She said, I feel crazy that I'm here and no one has an answer for me. I ordered an updated MRI with contrast. That's dye. Sure. It's a little bit more accurate when you can't figure things out. Still ambiguous in the findings. And here's the thing. This is a lesson, and it was a lesson for me. Patients know their body. Patients usually, and when it came to something like this, you can read a patient. And this is a patient who was clearly suffering from something, clearly very nervous about it, and really had no real answers for it, but knew something was wrong and knew that this was not her. MRIs are not 100%. No MRI is 100%, unfortunately. Sure. We're not there yet. So we get
it's the
there.
Best we have, but it's not perfect.
So, but it is. So it misses things, and again, it's a static study. The day that you're there, how you're positioned, how you're sitting, the tech that does it. There's so many variables that you can't approach 100%. But clinically, I knew there was something wrong. So I did something that I was taught. It said, listen, try to localize it, try to do a diagnostic injection, even just a temporary one time, see if you get temporary relief. And I did. She got temporary relief. So I localized it to her shoulder. I said, look, I was able to shut it down for a few days with some lidocaine. I think this is coming from your shoulder. The next step is, look, we really dive in. It's surgical, but clearly your body's telling you something happened to your shoulder that isn't typical. You went from super active on a daily basis to not tolerating a full day of work. Right. And not from lack of wanting to try, Mm-hmm. So we did a scope. I identified a tear that was missed. We fixed it. She was very diligent about her rehab. I mean, this is someone who, I think for 3 years, she was going back and forth with this. So for a long time as a young person was very nervous about this. Did terrific. Even after I cleared her to do everything, she came in a couple times to double and triple check that it was okay because she was so nervous about, going down this road again. And then more recently, she just sent us video and pictures. She competed in a big rodeo event.
Oh, that's awesome.
Won 3rd place. Was literally sent us a message how we changed her life. And this is just from trusting the patient, right. Really not dismissing them, knowing that nothing's 100%, and
not only
sticking
did you
with
trust the patient trusted you enough to go in, listen to you, and let you do basically exploratory surgery because you really
Correct.
Didn't know what you were going to find when you went in.
And that was a discussion we had. It said, listen, I don't know if I'm going to find something that is fixable or that can be addressed with this surgery, but everything is pointing in this direction. And at this point, if you're up for it, it's worth a shot, and I think it'll help. And yeah, it was a very good feel-good story because even I was a little nervous going in because you don't know with these diagnostic arthroscopies,
Right.
but very very rewarding in terms of that.
No, it sounds great. Um, and you helped her get better because that's at the end of the day.
That is well.
People sometimes people don't understand. The more you're injured in my industry, the more you're going to get paid, but the more pain you're going to live in the rest of your life. I'd rather get a little bit less money and have a great recovery from somebody, and so I'm sure you feel the same way. You feel
Absolutely.
good about that.
Yeah.
Tell us what body parts you do procedures on so our people watching will know, our audience will know.
Sure. So the majority of my practice comes in. Most of the folks are shoulder, knee, and a fair amount of elbow and ankle. I do very complicated shoulder surgeries, most of it arthroscopically. I feel very comfortable with that, as well as knee. I mean, I even do very complex multi-ligamentous knee injuries. I've treated MMA guys that really twist and turn and rip everything.
Yeah, we'll talk about that because we're partners with the CFFC, which is the step below the UFC. And we represent a lot of those guys.
I've worked with some of those guys too. But yeah, so knees and shoulders are the majority of my practice. I certainly do ankle arthroscopy and ankle ligament injuries and elbow injuries. I don't really do much hip surgery in terms of hip arthroscopy. And the honest truth is I didn't get much training on it. There's a big learning curve in terms of volume, and I just don't have the volume. And that is something that I leave for someone who's a little bit more subspecialized in it.
All right, so if somebody has an extremity, whether it's a knee, shoulder, ankle, or elbow, how do they contact you?
So we have our website, landaspine.com, which is probably the easiest way and has our information. And they can also call the office at 201-753-8862, and we'll be more than happy to help.
All right, appreciate your time here, and thanks for coming in.
My pleasure. Thank you for having me.
Great to have you live. Thank
Pleasure.
you very much.